All right, let's dive right in. In this explainer, we're focusing on that incredibly critical window, the time between a patient hitting the ED with chest pain and when we, the surgical team, actually get that call. We're going to bridge the gap between that initial triage and the definitive surgical evaluation for acute coronary syndrome, really zeroing in on the signals that demand our immediate attention.
So here's the central question we're tackling today. The standard STEMI alert, that's pretty straightforward, but we're going beyond that. We're talking about the less obvious cases. This is all about recognizing those subtle ECG and biomarker patterns that absolutely scream high-risk anatomy and identifying that patient who, without you, is right on the brink of a catastrophe. So let's start with the first, most powerful tool we have. Everything starts right here, in those first 10 minutes. This is ground zero. The 12-lead ECG is our first and, frankly, our most powerful tool. Getting a rapid, expert interpretation is completely non-negotiable. Now, there's a reason the guidelines are so strict about this. A door-to-ECG time of 10 minutes or less isn't just some quality metric we track. It is the foundational step that every single decision after it is built upon. Any delay here, well, it can have massive consequences for myocardial salvage, our ability to save that heart muscle before it's gone for good.
Okay, so what I love about this slide is the nuance. Look, we all know the basic 1 millimeter in 2 contiguous leads rule, but the real precision, the art of it, is right there in leads V2 and V3. You have to notice these specific, higher voltage thresholds that are adjusted for both age and sex. These details are absolutely crucial for avoiding false positives and making sure we correctly nail those true anterior wall MIs.
And this is where the ECG really becomes our roadmap to the coronary arteries. The pattern of ST elevation doesn't just tell you if there's an MI, it tells you where the occlusion is. You see anterior changes in V1 to V4? You're thinking left anterior descending, the LAD. Inferior elevation in I, 3, and AVF? That points you to the right coronary artery, or maybe the left circumflex. This isn't just an academic exercise. This is the very beginning of our surgical planning. Okay, so let's move beyond the basics. This is where a surgeon's eye becomes absolutely critical. We're now looking at patterns that don't meet those classic STEMI criteria, but they signal coronary anatomy that is just as dangerous, if not more so. These are what we call the STEMI equivalents. First up, Wellens syndrome. When you see these characteristic deeply inverted or biphasic T waves in V2 and V3, and this is key, often in a patient who is currently pain-free, that is a code red warning sign. It's telling you there is a critical high-grade stenosis in the proximal LAD. This patient is literally harboring a widowmaker lesion and is at an extremely high risk for a massive anterior MI in the next few days. Next, we have D. Winter sign. Now, there's no ST elevation here. Instead, you see this very unique pattern of upsloping ST depression that leads right into these tall, peaked T waves in the precordial leads. Make no mistake, this is an acute LAD occlusion. It's a direct equivalent of an anterior STEMI, and the cath lab needs to be activated immediately. And here is where it gets really interesting for us as surgeons. When you see ST elevation of 1 millimeter or more in lead AVR, especially when it's paired with widespread ST depression everywhere else, your mind has to go straight to a left main coronary artery occlusion or severe 3-vessel disease. This is a pattern that very often predicts the need for emergent CABG.
So what do we do with those ECGs that are notoriously tricky to read, like a patient with a left bundle branch block or a paced rhythm? Those conditions can completely mask the typical signs of an MI. Well, the Scarbassa criteria give us a scoring system to cut right through that noise. By looking for these specific concordant ST changes, a score of 3 or more is highly specific for an acute MI. You have to treat it as a STEMI equivalent.
Okay, so we've covered the critical ECG patterns. Now let's shift gears to the second pillar of modern ACS triage, cardiac biomarkers. The arrival of high-sensitivity troponins has completely changed the game in terms of our diagnostic speed and our precision. The European Society of Cardiology's 0 to 1 hour algorithm is really the new standard of care. It's a fast, dynamic assessment. We're not just looking at a single value anymore. We're looking at the absolute change, the delta, over the course of just 1 hour. This kinetic approach lets us stratify patients much, much faster and with a lot more confidence. But here's the real-world clinical challenge. What this chart shows so clearly is that while the algorithm is fantastic at quickly ruling patients in or out, it leaves a massive group, fully half of all patients, stuck in this diagnostic gray area.
This observe zone is where our clinical judgment, our risk stratification, and very often a surgical consultation become absolutely paramount.
And here are the actual numbers that drive that algorithm. Just using the Roche assay as a common example, you can see the really low thresholds we use to confidently rule out an MI and the pretty clear-cut values for ruling one in. The challenge, of course, is that every single patient who falls between those precise cutoffs lands right in that diagnostically tricky observe category. So, how do we handle this huge observe zone? Well, this is where we connect the dots from diagnostics to definitive action. We use validated risk scores to find the truly high-risk patients hiding in that group, the ones who need invasive management and a surgical consult.
We've got two main tools in our belt here, the TIMI and GRACE scores. Now, TIMI is simple. It's useful for a quick initial look. But the GRACE score is far more robust. It pulls in more clinical variables like signs of heart failure, and it has much better power from predicting mortality. And here's the crucial part for us. It's the GRACE score that directly guides the timing of an invasive strategy. And this is the number that matters. A GRACE score greater than 140. That identifies a patient as high risk. This is your trigger. It's the threshold that should prompt an early invasive strategy. We're talking angiography within 24 hours, and it gets the heart team ready for a potential surgical intervention. Okay, we've covered a lot of ground, from that initial ECG through the biomarkers and into risk scoring. Let's boil this all down into the most critical, actionable takeaways for us on the surgical team.
So what are the key points to remember? First, train your eye for those STEMI equivalents, Well-ins, De Winters, and that AVR sign. Second, remember a Scarbassa score of 3 or more in a bundle branch block, that's an MI until proven otherwise. Third, understand that the rapid troponin algorithm, as great as it is, creates this huge observe group. Fourth, use the GRACE score, specifically that magic number of greater than 140, to find our surgically relevant high-risk patients inside that group. And finally, and this is so critical, never forget your role in the initial triage of patients who show up in cardiogenic shock or with suspected mechanical complications. Your early involvement can literally be life-saving.
And that really brings us to our final thought. Our diagnostic tools are getting faster, they're getting more sophisticated every single year. So the ongoing challenge for all of us as one cohesive heart team is how we can better integrate all these early, subtle signals, the ECG patterns, the troponin kinetics, the risk scores, to streamline our communication and our decision-making. Because the ultimate goal, always, is to shorten that critical time from the ED door to the OR table. Thank you.